One of the other things that people hear about and sometimes talk about, and that we've actually studied in the foundation, is this concept of enhanced recovery after surgery, or an acronym that's called ERAS. And I'd love to hear from our experts what their experiences have been with that, what the promise of ERAS is, maybe what the challenges are, and if that's something that patients should be looking for when they are going to have their treatment. We'll start with you, Dr. Wang.
Well, ERAS is a fascinating concept, and we instituted it at the University of Miami to change the way people are fast-tracked through surgery. And, the hospital loves it because the amount of cost savings are tremendous. Patients, of course, benefit because they mobilize faster, they have less pain. And there's another dimension of this I think it's worth entertaining, which is we tend to focus on the fact that people come in on meds, and then we give them more meds after surgery. But there's also a different subset of patients, which is actually quite large, which is people that are not getting help with surgery. So people either out of fear or miseducation or lack of referrals or resources end up being told they just got to live with this pain that in many cases can be fixed with a surgery. And so surgeons are at this crossroads, right? We try to be conservative, but also fixing people properly is another way to reduce opiate dependence and exposure.
Yeah. Dr. Nandini, are you experiencing ERAS protocols in your hospital?
Yes, we've implemented ERAS protocols. We've implemented it primarily around awake spine surgery. Wow. Because we want to perhaps not even use any anesthetic, a spinal anesthetic, but no general. And then we need to mobilize those patients quickly, and often they discharge the same day or the next day. But this can be done with a protocol which everybody follows, and all the resources are applied appropriately up front in order to optimize patient outcomes.
Yeah, and so with ERAS, there is a decreased need for pain management, right? That's part of the thing. Dr. Shuba, what are your experiences with ERAS?
Yeah, just to kind of jump on the idea that we're all talking about, again, the education and the thinking of this about an insult with surgery or an incision and having pain afterwards. So there's a lot of data now, and this comes out through our ERAS protocols, where you give medicines before the surgery, the same medicines. And what that does, it almost numbs the patient up. And because there's some data showing that the longer someone is in pain, the more the body reinforces that to the brain, whether it be the pain itself, or as Dr. Wang said, with kind of an affective, meaning an emotional response, which is the suffering aspect of the pain. So if you can numb someone up through what we call pre-medical or pre-surgical ERAS, that's part of it, then when they have the insult, it's almost like if you were to, hit me in the arm after I'd already numbed my arm up, I wouldn't feel it. And then when the insult went away and the medication wore off, I might not need any medication whatsoever. So that's a little bit oversimplification. Yeah. But the fact of the matter is the ERAS starts actually before surgery and gets the patient ready so they have less stuff during and less stuff after surgery.
So it's almost like a prehab situation, right?
Right.
Yeah, Dr. Gell, how about you?
Yeah, so all fantastic points. I mean, one thing to point out that ERAS, there's a lot of components to it, but what we're talking about is the opioid minimization component. And what we've introduced, and I think all these guys have done this as well at their centers, is we start off with the cocktail before they go to the surgery, like Dan was talking about. That helps.
The drug cocktail.
The drug cocktail, right? Yes, that drug cocktail, right? That's Tylenol, maybe a gabapentinoid, maybe some sort of NSAID in some centers, and potentially acetaminophen or Tylenol. So the other components of it, which is relatively new in spine, is regional blocks, right? So erector spinae blocks, if you get a total knee, right, typically they're giving you some sort of regional block to reduce that pain exposure. So now we're introducing those in spine. Also at our center, when they go to sleep, they get no opioids for the most part. And it used to be the opposite of that, right? So if you talk to the anesthesia folks, when you put somebody to sleep, there's pretty much a hard stop on every single medication, right? Because it becomes toxic at a certain level. There's not a hard stop in opioids. You can put somebody to sleep, and as long as the airway's protected, you could back the truck up and put as many opioids as you want. But that delays their recovery. They don't get up, they don't mobilize quick. So we're reducing opioids when you're asleep. We're using regional blocks to help, right? And then the other thing is we've standardized the way we treat the pain afterwards in the hospital, right? When we first looked at our data, between 8 partners, the variability was massive, right? So now we standardize that and we escalate it appropriately. So there's a lot of components within ERAS, then there's a lot of components just within the opioid minimization component of it. And all these guys are helping lead the way on how to fight that component.